Our next speaker is a terrific new member of the Consortium. Dr. Walter Kaufmann is a senior associate in neurology at Boston Children's Hospital and visiting professor of neurology at Harvard Medical School. He's co-director of the Translational Neuroscience Center, director of the Rett Syndrome Program, and co-director of the Fragile X Syndrome and Down Syndrome programs. His research uses a multidisciplinary approach to understand the basis of cognitive and behavioral problems in children with genetic disorders that are associated with intellectual disability and autism. Walter is also a member of the Neurodevelopmental Disorders Workgroup of the DSM-IV, which is responsible for the new diagnostic criteria for intellectual disability and autism. Walter, we very much look forward to your remarks. Please welcome Dr. Walter Kaufmann.
Okay, thanks. First of all, thanks very much for inviting me to give this talk. I'm representing the DSM-IV committee. I have been honored to be a member of the committee. And the reason why I joined, and I give you a perspective of how this process took place, this is one of the most multidisciplinary committees in DSM-IV. I am a child neurologist. There are psychologists, child psychiatrists, speech and language pathologists, because this represents the reality of the treatment and the management of individuals with autism. So I have organized the talk in using as inspiration my usual use for source of inspiration, which is Monty Python. These are very fundamental questions. If you have seen one of the recent commercials with John Cleese, you understand what I'm talking about. So what I'm going to talk, this is the issue. DSM-IV is going to be published in the spring of 2013. Now it's going to be different. It's a new era, so it's going to be a book, a website, a CD, etc., etc. But the big news that affects autism, the autism field, is the fact that it's a single diagnosis. So a large component of the new criteria are finalized. I'm going to talk about those. I am not going to talk about things that are not finalized, so we are very careful, the members of the committee, not to create confusion and to talk about things that are really much more settled. But at the outset, I want to say what are the concerns of the community. This is something that we hear all the time, that DSM-IV comes with problems, that we have sacrificed sensitivity for specificity by, among others, merging the social interaction domain with communication. The fact that we're merging the different diagnoses into a single one also is going to lead to the loss of identity of some groups. That the research studies are not going to be comparable. Why are we going to change DSM-IV? This is going to change epidemiological studies. It could affect delivery of services. But if you go back, the reason why we need to do this is that for the last 50 to 60 years, through different versions of DSM, this new entity has emerged. It wasn't until 1980 where explicitly autism was on DSM, on the DSM-III version. And that has been the evolution until then 1994, DSM-IV was published. Very little was done in 2000 in terms of changing criteria. But I'm going to get into a minute why. First of all, the WHO, so I get to acknowledge my colleagues. I mentioned I am honored to be a member. On the left, you have the list of members. One of them resigned, and all of those with an asterisk have been active from the very beginning. And I had to particularly thank Sue Swido, who is the chair of the group, and Kathy Lord for providing a lot of the material that I'm going to present today. It's a large committee, diverse, as I mentioned before. We had advisors for different topics. Remember that our job is not only autism, but we have to deal with all developmental disorders, intellectual disability, learning disabilities, communication disorders, so we have a big task. So how we do this? We have done it through teleconferences, in-person meetings. It has been 5 years later, and we haven't finished yet. It has been more than 2,500 hours of work. We have literature reviews, and I think that's something that is very different about DSM-5, and it's not only in our committee, is that this is the DSM version that has to be most data-driven. We want to be based on evidence. And of course, we can deal with the evidence that is in front of us. There are many issues that had not been addressed. There is very limited literature, so we have to deal with the available evidence. And we have consulted a number of people outside DSM. You can see some of them are members of prominent organizations that are important, in this case, in the autism field. And at this point, for the most part, all autism support groups have agreed with us. There are only 2 that are in disagreement with the criteria. But now the most important question, why? And this is my own list. I mean, most of what I'm presenting are more or less official slides, so we're on the same page with all of the members of the committee. But this is my way to summarize the things that I think that are not working. And this category of pervasive developmental disorder, what is that? It's really a very confusing one. As you know, Rett syndrome is there, and I'm going to explain why and why it shouldn't be there. And the second, probably even more important, how consistent and reliable are the diagnoses? Some diagnoses like high-functioning autism versus Asperger. I mean, it's almost like flipping a coin. How appropriate are the diagnoses? And this is into the issue of validity also, which is a very difficult one for any mental health disorder. So we use pdd-nos when we don't have a better label. And we all do. I had to tell you that among the members of the committee, when we decided that this category was not going to be any longer, this diagnosis, what are we going to do now? It's so convenient. And so when someone in the high functioning and has unusual behaviors, we use Asperger. It seems to sound better. We don't have a better explanation. So we have been using this diagnosis not in the way that they have been intended. And what's the validity of some of the diagnoses? They were decreed by a committee with very limited data. We're trying to change this, and I'm going to show you. We probably are not in a perfect situation, but I think we have come forward and we have made some progress. One thing for people to remember is that DSM-IV, that was published in 1994, introduced some of these entities. These entities are not very old. As I told you, the word autism emerged in DSM only in 1980. So these entities, the fact that Rett syndrome is there, childhood disintegrative disorder is also part of DSM-IV, as well as the new description of pdd-nos. Asperger also was added to DSM-IV. So one of the problems that we face is if we are going to have a point of reference, what is our point of reference? DSM-IV is not necessarily the gold standard. I mean, we think that it's not working for the reason that I enumerated. So what will we use? And I think this is one of the difficult questions. Still, the global impression by an experienced clinician is still a very good way to know that something's wrong with the child. The child is in this category of autism. The ADI and other of these gold standard measures are very good, but they are really not used in the clinical practice. Particularly the ADI, it takes a long time to get this information. They are used more in research. They are not really something practical. DSM-5 or DSM is not for research. It's for clinical use and use in all possible settings, not only in academic centers. We face the reality that in other countries, in Europe and elsewhere, people are using ICD criteria, which is the diagnostic coding that is used for other disorders. It's only mental health disorders that have this unique sort of dictionary or Bible called DSM. In the rest of the field, in neurology, ICD is what is used. And the fact, the reality is that the CDC has begun to use for a long time the word autism for all of these categories. So it has created additional confusion. Now, this is one of the most confusing entities that we had to deal with DSM-IV. It's really not pdd-nos. I think it's really, we think that it's pdd-NVS, which is not very specific. because it's like a sort of milder version, incomplete version of autism, and that "or" is a very important one. It's one of the typo errors that was corrected in the 2000 version, because you have the key central core component of social interaction, but you can have the stereotypic behavior, or you can have the verbal or nonverbal communication component. Yet, you can use it also for atypical autism. And by the way, if you have subthreshold symptomatology, you can use it also. Very non-specific. And so the other thing that has happened since 1994 is that autism has become the most prominent developmental disorder. And a lot, I think that Dr. Fishbach's first talk was a good introduction into why DSM-IV has to take into consideration the explosion of knowledge in autism. It's a behavioral disorder. It's still a syndrome. We need biomarkers. We don't have a biomarker for autism. We don't have a blood test for it. It's still a behavioral construct. We know there are multiple etiologies. I am also repeating what Dr. Fishbach mentioned. This genetic environmental interaction, and we know more about the genetic factor, but the environmental factors are there. And it's a lifelong disorder. You may not have disability now because the systems are in place to help you, but still it's a lifelong challenge. So you need sustained support. We think it's important to do to make an early diagnosis, because intervention can be instituted early, and they could make a difference. Even though the example of Rett syndrome, or one of the Rett mouse models, is that it's never too late. It probably is better to do it early. So these are very different situations that what Kanner faced, or when he identified the disorder, where at that point it was a childhood disorder. Now we know that we need to go before childhood, and we need to think after childhood. And the framework under which autism has been defined, it has been essentially boys between ages of 3 and 12. So, and that's no longer useful. The key issue is this selective or greater impairment social interaction, because now we acknowledge there are many children or many individuals who have autism, who are in the spectrum, who have lower intellectual abilities. And you are wondering, why is this happening? Is this really social interaction is as impaired as the rest of cognitive and abilities, or is really a selective or greater impairment? And the fact of the matter is that one of the reasons why we need to think about the spectrum is because, the users of the system, meaning the users of DSM, the clinician began to talk about autism spectrum before we even began the discussion on DSM-IV. As part of the conceptual framework is that now the story has been very complicated. The three central circles are DSM-IV, but we now know so much more about other diagnoses that have an interface. Social anxiety with social impairment. We need to make the distinction. Not all social interaction disorder is autism. There could be social anxiety. And social anxiety could be comorbid with autism. So this is the complexity that we have to recognize, we have to face in DSM-V. Obsessive compulsive disorder obviously has a connection with restricted and repetitive behaviors. So let's talk about specifics. So what is changing? First of all, I mentioned the category is less than desirable. And first of all, the term is very confusing. I remember having spoken with Tony Charman, who is one of the leading researchers in autism in the UK. So pervasive, that term it's an American term. We don't use that in the UK. It's like, what is the nature of pervasive developmental disorder? They are not pervasive, they're very specific. They had to do with social communication plus restricted and repetitive behaviors. And we have the problem with the overuse of pdd-nos and creating this, in part, perhaps the autism epidemic is the consequence of the overuse of pdd-nos. And there is a tremendous overlap between pdd-nos and Asperger. So that's the reason why we prefer the term of autism spectrum disorder as a category and diagnosis. So that meant to remove some of the diagnosis from the mix. And Rett syndrome is one of them. I mean, the autistic behavior that could be very prominent in Rett syndrome are in a very specific time period during the regression phase. So if a child is before regression or after regression, doesn't have necessarily the autistic features, they don't have a threshold, they don't reach a threshold level. And And why Rett syndrome? And why not Fragile X, which is more common, and it has, like Dr. Fishman mentioned, it depends on how do you define. If you you define autistic disorder, the very restrictive definition, we're talking about 20-25% of the children. If you talk about this more liberal definition, the whole spectrum, we're talking about 50%. Why is not Fragile X there? What is different about Rett syndrome? And I think it reflects some of the arbitrary nature of DSM-IV. What about childhood disintegrative disorder? This diagnosis emerged in 1994 at a time in which we knew very little about regression in autism. Now we know much more, and when you dissect carefully what we know about regression, you realize that very few patients meet diagnostic criteria for CDD, and many of those have other symptoms that suggest that we're talking about neurologic disorder with a sort of degenerative nature, like a metabolic disorder. We are not talking about something very specific, very selective, like autism. So this disorder should be eliminated. What about Asperger? And this is one of the most challenging issues and one of the most controversial issues, is that, well, it's a new entity. It was introduced in 1994, and actually, interestingly, the cases described by Asperger don't match the Asperger definition on DSM-IV. But the most important thing is what is there in red, that this is an extensive look at the review of the literature, indicates that there is no very good distinction between high-functioning autism and Asperger. And there are some diagnostic biases. It's very interesting that, I didn't use the word richer, that's what they're given to me, but to make the emphasis that higher socioeconomic levels and certain ethnic groups get the diagnosis of Asperger, while other children, the children in lower income minority, get the diagnosis of pdd-nos, reflecting in part how practice or medical practice is in the United States. So for all those reasons, the category is no longer valid as a multiple diagnosis. They shouldn't be there. So we're talking about a single entity. There is important scientific evidence supporting this continuum, this spectrum. And I'm going to show them the evidence in a minute. By the way, I know that many of you are interested in the slides. They are busy slides. I have a lot of information. So I'm going to ask you two things. To hold your question until the end, but I promise that this material is going to be available. Not only you are going to have the opportunity to see this video again. I don't know if you want to do that, but anyway, at least you can read. You can turn the speakers off while you're reviewing the material. Probably is better. So I think that the evidence that we're talking about a spectrum come actually from the Simon Simple collection, and this is data provided by Kathy Lord. And even though this project was put together in the best possible way, and Kathy devoted a lot of her personal time. I think she was on a sabbatical doing this. This is the example of a very well designed multi-site study. And guess what? Those 13 sites had a very different profile of diagnosis. And these are the DSM-IV diagnoses. So you have some in which Asperger and pdd-nos visually doesn't exist on the left, and some in which the three diagnoses are more or less in balance. So what's going on? Does it represent different populations? Well, to make the long long story short, when you look at a number of parameters, and this is an example, this is a social effect as a new construct coming from DSM-IV, what you see is pretty much a bell curve. So you look at each one of these sites with a very different profile, shows pretty much the same distribution of a key parameter, a key core feature of autism. So it shows you that really what you have is a continuum, a spectrum, a range of social interaction impairment that gets different labels, because these labels are difficult to apply and they are not consistent. And that's the reason why it's important to modify the criteria and to get to a single diagnosis. having said that, a single spectrum doesn't mean homogeneity in any way. And how do we capture the heterogeneity, the individual features? And I think that a very important issue is that we are putting emphasis on DSM-IV in recording specifiers, other information, severity of symptoms. And I'm not going to show how we're going to record because it's still not final. But severity of symptoms is very important. Pattern of onset, clinical course. Do we have regression in the history? Any etiologic factor has to be recorded. If a child has a mutation, if a child has a syndrome, if a child has a medical condition, it should be a place and should be recorded. It should be part of the diagnosis. It's the only way that we are going to understand the full picture and the complexity. Cognitive abilities, and perhaps language abilities, perhaps the best expression of overall cognitive ability has to be recorded to understand where is that child in that spectrum. And associated conditions, I mentioned before, they could be overlapped with ideologic factors. So one of our challenges is not only to convince everyone that we now had to get rid of all these other labels and we had to have a single diagnosis, a single category. That's the first challenge. But the second challenge is to tell the clinician, you had to collect this information. This is as important as to put the label autism spectrum disorder, because you'd say only that, you are not describing that particular individual. So the second major change is we went from 3 to 2. And as you remember, there was this very complex algorithm with 6. There had to be 2 from number 1 and at least 1 of each one of 2 and 3. You know what I'm talking about, the social interaction component, then the communication, and then the restricted and repetitive behavior. So you had to have 2, at least 2, 1, 1 to have the diagnosis of autism. So when we came to analyze the data, the communication component was emphasizing too much verbal skills. Language and communication components were not critical for social interaction. So that's the reason why socialization and communication have been merged into a single entity. And like you said in the slide, it de-emphasized language skills, and I think that led to a lot of double counting. So a child with a language delay, not necessarily a problem with language pragmatics or the use of language for social interaction, was getting 1 point for the language delay, another point for the use of language. And I think that contributed also to these the challenges with the application of DSM-IV. So these are the new criteria. And I know it's a very busy slide, but I'm going to go over this briefly. So like I mentioned before, now we have 2 domains, essentially, two components. And one of them is the most, I would say, obligatory. It's not the core, because it's interesting that whatever we did in terms of data analysis, we have a number of hypotheses when analyzing data. This is going to be it's going to segregate with that, doing factor analysis. It turns out that data, this is the nature of science. Data show you that many times you're wrong. Your assumptions are wrong. And one of the things that I am in the group of more interested in social interaction people, we have the engine, social interaction, and this caboose was coming no matter what, the restricted and repetitive behavior, whichever analysis we're doing, it was coming. It was so intrinsically interconnected with social interaction. Nevertheless, the engine, the critical component is the social communication. As you see, that's the reason in the new criteria, we require a deficit in all 3 components. The social-emotional reciprocity, the one on nonverbal communication, and the one on developing and maintaining relationship. The individual had to have the deficit in all 3. However, in the case of restricted repetitive behaviors or interests or activities, you can have at least 2 of them. You can have more, but at least 2. We have introduced a new component, which is based on our new knowledge about other components of autism spectrum disorder and early ages, that hypo reactivity to sensory input is an important component as much as the restricted and fixated interest. So we're introducing that, and we think it's particularly important in younger children. And the symptoms have to be present in early childhood. and we don't have a particular age. And the important point that we're making is that the dysfunction produced by this disorder may not be evident because it may be the result of a balance between the service, the support that the individual has in the environment and the intrinsic limitations of the disorder. So it may not be obvious even during early childhood. So this is another busy slide, but the point that I'm trying to make here is that this is, having said all this is not that different. We were able to map most of the components of DSM-IV to DSM-V. And you see in color those that now are merged, like, for instance, social-emotional reciprocity and shared enjoyment are now a single social-emotional component. And there are, of course, the communication, a number of the communication domain components are no longer there. But most of those, the restricted and repetitive behavior, have mapped to the same equivalent domain in DSM-V. So this is not the radical departure that from DSM-IV as you will think. DSM-IV was a good base for our work. So some examples, we have refined some issues. For instance, this is an example, on DSM-IV, failure to develop peer relationship and social play. Now we are trying to, refine that by, labeling this a difficulty adjusting behavior to different social contexts. So the peer relationship is part of that, as well as social play. And this is another example in which this very strict age limit prior to age 3 now is much more flexible because it reflects the reality of early intervention, of environmental factors that can lead to less dysfunction. Other changes, I mentioned that we're putting emphasis on collecting more information. So we talk about the symptoms, and that's obviously the number one component, age, but this other information is critical if we're talking about a spectrum. So we want to make sure that we capture all these, the specified, the verbal abilities, the cognitive abilities, the associated medical conditions, the severity of the symptoms. And what we're going to provide along with the criteria are examples. So these are examples for a specific age and divided by verbal or cognitive ability. So it's going to be very different. We're talking about nonverbal adolescent, we're talking about a nonverbal toddler. Now the other this is another business slide, don't worry, you're going to have access to this, is that part of the problem was that not everything was so neat. So clearly emerged this new category, this new diagnostic, which is, for a number of reasons, we think that belongs more to communication disorder than to a group with autism, but obviously is in many ways the sort of the cousin of the autism spectrum disorder, social communication disorder. So what we're talking about here is language pragmatic deficit plus, in which the use of language for social interaction, and you can see the use of communication for social purposes, it could be even nonverbal communication, the ability to change communication with context, that's a sort of mental flexibility in the context of social communication is affected. There is nothing about restricted and repetitive behavior. This is really key elements of communication that you can see in the social communication component of autism spectrum disorder, but isolated. And if you add this category, I think we have a better picture of children who have all these or not only children, but adults who have social interaction disorders. So it's the appropriate complement to autism spectrum disorder. So, in fact, some of the children that now we label as pdd-nos, not because we don't have a better label, but because we think that they have elements of autism, but we don't have a better label, and don't have clearly the restricted and repetitive behavior, and we're not sure about the communication, may fit better in this social communication disorder category. And it turned out that in the field trials, which is another component of, it was present in previous version of DSM, but now it has been a complement to data analysis and review of literature. We also have conducted field trials in different settings, academic centers as well as more primary care practices and real-life settings. Actually, not only autism spectrum disorder did very well in terms of reliability, but also social communication disorder. So we think that we have a second entity that could help to fill that small gap. And you see the reason why we think that will create more confusion if we put it together with ASD. Now, these are the trials. These are places where they have been done. Stanford, Bay State Medical Center, Columbia Cornell. Those are the numbers and different visits. And one interesting thing that I don't have a specific slide for that is that autism spectrum disorder was one of the diagnoses with the highest level of reliability of all the pediatric DSM-IV and probably of all DSM-V. We were quite surprised. So that's good news. But reliable, again, is not valid necessarily. So I don't like this title. I am presenting because it was given to me this way, because it emphasizes that when you say sensitivity and specificity, assume that you have a point of reference, a gold standard, and DSM-IV is not. What I will call this level of agreement between DSM-IV and DSM-V. So what you have there is the DSM-IV diagnosis. You have those who don't have any diagnosis in the spectrum, those who have the diagnosis of autistic disorder, Asperger, pdd-nos. So what happened if you apply DSM-V criteria? As you can see, the number that do not have a DSM-V diagnosis is pretty high. Is the majority of those 214 is 185. But some of them actually end up with the diagnosis of ASD. So this idea that we are losing sensitivity is not proven by data, by the field trials. And those with autistic disorder, and this is something that we knew, autistic disorder was probably of all the diagnoses of DSM-IV the most consistent, the most reliable. And it has been proven that it's a very high level of agreement between DSM-IV and DSM-V. Asperger disorder, actually, most of the individuals with Asperger end up having ASD. Some end up having social communication disorder, and some end up having 14%, it's a small number, sample, but it's nevertheless 14% of them end up having nothing under DSM-V. pdd-nos, again, was, as expected, the most variable one. So of those, the majority end up having ASD, but some of them end up having social communication disorder, and 22% end up with no diagnosis, neither ASD nor social communication disorder. So that exemplified the problem with the pdd-nos. So where are we going from here? I think that the field trials and all the work that we have done have shown that in fact DSM-V is not a huge departure from DSM-IV in terms of being able to capture children or individuals in general. This has been, by the way, the field trials were done pediatrics, so the data we have for testing DSM-V is pediatric data. But obviously, as I mentioned before, we're thinking of DSM-V to be used throughout the age range. But in terms of pediatric data, we think that there's no big difference in terms of sensitivity with respect to DSM-IV. Well, a specificity is difficult to say because you need to have some gold standard to say that this is really specific. And the question of specificity and validity had to be addressed in a different way. So right now, what we have is we are reviewing videos. So the field trials were done in such a way that we were completely removed from the process. Were done by a completely different group of people. The authors of DSM-V were not involved. So we're getting now the material, we're getting the data, we're getting the videos, and we are looking at the videos and trying to figure out among ourselves if we agree with whether this child was in the spectrum or not, because I told you that there are not very good gold standard, and still probably an experienced clinician is the best gold standard. But we need also prospective data. So this is retrospective review. The long-term test of DSM-V is going to be like anything in science, time and multiple studies. We will have to go over time to see how DSM-IV criteria is really applied, what is the final outlook of this. Now, this is, I put it in red because it's my own point of view. I have been very concerned about the circular argument that we use DSM-5 based tests like the ADR-NA-DOS to supplement the DSM criteria. Guess what? There's high level of agreement. What a surprise. So, but there are other tests, there are measures, and those are included in the Simon's project, like the SARES. Even the ABC, the Abraham behavior checklist, the social withdrawal scale is informative about social interaction. So there are other ways to provide convergent evidence. And there may be other measures down the road. Hopefully will be some type of biomarker that we can use to address these issues of sensitivity, specificity, reliability, and validity of DSM-5. I only wanted to mention that we did this study in Down syndrome, trying to answer the question whether it really was an entity of autism in Down syndrome. And what we did was actually to use the ABC, the social withdrawal scale, and we showed there was a cluster that was really identified, and we used positive and negative control. We compared with ADHD in Down syndrome and with children who didn't have anything. We had positive and negative control. So it really, there are other ways to show that there's a group of individuals who share a behavioral phenotype that we call autism by other means. And I think that's the long-term legacy of DSM-5. We have done our best, and I'm not apologizing for the group. We work as hard with the best possible data we have. And I think the APA has been very visionary in the sense that the change from the rubric number is because this is DSM 5.0. We expect there's going to be a DSM 5.1, DSM 5.2. We're going to be updating this according to the data we're receiving. And it's not we are in the 21st century, so we don't have to release a book every 10 years or 15 years. The world is more dynamic, perhaps too much dynamic, too much online. I'm sure my wife complains about my attachment to all these devices. This is a reality, but that makes the issue of the capacity to upgrade, to update diagnostic criteria much easier. So we think that this is going to be a dynamic process, and I think we're going to stay tuned to what research is showing, in which way we can get the most biologically solid in terms of foundation set of diagnostic criteria. Thank you.